Hello, everybody. Welcome back to the Barbell Therapy Podcast. I'm your host, Dr. Brett Scott. With me here today is Caitlin Johnson. Caitlin is a registered dietitian that specializes in managing PCOS for women. She is the creator of the PCOS app. She is the founder of PCOS Formularies. She has a course on managing PCOS, and she really helps women improve their symptoms, lose weight, and get pregnant. Now, before we begin, I want to let everyone know our podcast is sponsored by Ascent Protein. If anyone would like to order Ascent Protein or any of their other supplements, including creatine, electrolyte mixes, things like that, go ahead and use the code BRETTS10. So thank you, Caitlin, for coming on today. And this is a topic I really have been looking forward to talking about because for me, as a man, this is something I don't deal with. However, I've been out of school about 8 years now. And when I came out of PT school, it wasn't really a thing people were talking about or concerned about. And in the past few years, it seems like this is a condition that is running rampant among women. Women are very concerned about it. There's a lot we're discovering, I guess, or a lot more that's coming out with social media and things even. So I'm really excited to get into this today. So about PCOS, what is it that's happening, or what is making this happening kind of metabolically, physically, physiologically, all that?
Yeah. So, well, thanks for letting me come on your podcast and inviting me. Not only am I a PCOS dietitian, but I'm a PCOS patient. And so by answering your question, I'm going to start with what I was told PCOS was. At 18, I got a diagnosis. I'd gained about 50 pounds in 3 months while training for a marathon. And I thought eating pretty well. I mean, now I have a whole degree in nutrition, so surely I could have done it a little bit better, but nothing to constitute, that rapid amount of weight gain. And I went to the doctor and he said, I think you might have something called PCOS. We're going to do some testing. So we did testing that included labs. And then the other testing was an ultrasound. It's a transvaginal ultrasound typically, meaning they use a wand and they go up through your labia into your vagina and look closer at the ovaries themselves. They can't really see your ovaries from ultrasound like you think of in movies when you see women pregnant and they're kind of on the top of your belly.
Yep.
So it requires, or at least at that time, it required that type of two forms of testing. And then the other thing that they look for are signs of androgenism, hyperandrogenism, and that can either be in the lab work. It can be symptoms, so hair loss, growing hair in more of a male pattern, like chin hair, hair on your nipples, like stuff that you would think like, man, this doesn't make me feel very womanly, right? And then the other thing that they're looking at is cycle history. So your menstrual cycle, is it spread further out? Do you never bleed? They're actually wanting to try and answer the question of if you're ovulating, but they're doing it kind of indirectly by saying, do you have a period bleed? If you are not bleeding at all, you are not ovulating, period, end of story, unless you're pregnant. So they're going to ask those types of questions in a workup. So for me, they did the blood work. I had been on birth control at that point, so kind of the cycle regularity questions didn't apply to me. And they did an ultrasound, and I remember the doctor coming back in after the ultrasound. I'm in this like crinkly, scratchy paper still from the ultrasound. Didn't even have time to get dressed. And he comes in, he goes, I was right. You have PCOS. And I didn't even know what that was. So I thought he was telling me I had like cancer or something. And he said, well, I said, what's PCOS? He said, it's the number one reason in America women can't have babies. So like this is all the way back in 2003. Okay. So we're talking 22 years. That sounds scary to me to say because of what it means for me and my age. But it's not that this condition wasn't around. It's actually, we've known about it in medical research for over 100 years at this point. There's documented forms of it all the way back into like ancient literature about women who don't menstruate and they're strong like men, and they grow beards, and they tend to be the ones that make it through famine. Like they're hardier, stronger. There's some biological benefits to this, even though kind of in our modern world, they aren't so expressed in the way that we live our lives. But I say this because this is the type of message somebody's going to get typically when they get their diagnosis. It's going to be hard to get pregnant and you need to go on medication. But doctors aren't by and large explaining what PCOS is. And it's becoming more common having conversations with somebody like you, Dr. Brett, that women in, I think, maybe the benefits of social media and kind of this access to information culture that we're a part of. People are talking about what they're going through. People like you and I have platforms to reach out to people saying, hey, we know what this is and we know how to help. And women are kind of changing and saying, I don't just want birth control for every problem you think I have. Anxiety, depression, hysterics, irregular periods, painful periods. A lot of us are saying, I want to know more and get to the root cause. I don't just want to slap a Band-Aid on this, which is what, I think I don't want to come off as anti-doctor. I'm really not. I think that we need to all come alongside one another and say, this is what I have to offer you, and refer out to the people that can help you with the other sides of it, because the doctor has surgery and medicine typically, and that's about it. And what he offered me were medicine. He said, you can go on metformin. It's not for PCOS, it's for diabetes, but it might help you with your weight, and go back on birth control. Come back when you want to get pregnant. We have different medicine. So most people are getting a message like that, and they have the exact same question you have. What is happening? Why does it seem like there's more people? The statistics show there's like 1 out of every 6 women has PCOS at this point. They used to say closer to 1 in 10, and then 1 in 8. Some research is pointing closer to maybe 1 in 4. Oh. And so what does that mean? Are we getting better at defining it, or is our behavior and kind of the expression of our genetics saying it's easier to develop in kind of this more sedentary world where we're eating a lot of hyper-processed foods? So there are metabolic pieces of this. There are endocrine pieces of this. There are genetic pieces of this. It's kind of like having, when we talk about stress buckets, it's like you may only have a certain amount of a container. And we throw in a little bit of stress from work, and we throw in a little bit of stress from your marriage and finances and this and that. And eventually something is like the straw that breaks the camel's back. I feel like with PCOS, it's a similar thing. It's your genetics play a role. We know that because you're more likely to have it if you have a sister or your parent, your mother, or an aunt that has it. So we know that there has to be some sort of genetic component. We know that there are lifestyle components. We know that there are components that have to do with age. We don't diagnose this when you're prepubescent because you aren't menstruating and we don't have these hormones to check. But by and large, we're looking at a population that tends to be overweight or obese, that struggles with insulin resistance, and these metabolic abnormalities trickle down to hormonal abnormalities that tend to be what yields a diagnosis. I'm struggling getting pregnant. I don't have a period. I have really painful periods of time, and people would describe having like a cyst burst on their ovary. That's actually not a symptom or an outcome of PCOS. It's just typically when they find PCOS because somebody's having extreme abdominal pain, they're ruling out appendicitis. They look at the ovaries, they see something ruptured, which could have just been a normal ovulation. And they're saying, well, it's probably this. And also you have PCOS. And so we often find it at the same times. But it's a complex physiological issue that we don't know the one thing that causes it, because it's not just one thing. And we used to treat it mostly like a gynecologic issue. You're struggling to get pregnant, you're not having regular periods, but we see women who even age out of menstruating years still struggling with the effects of PCOS. So we know that it doesn't go away if you remove the ovaries, it doesn't go away if you remove the uterus. because it's not really the ovaries that are the only thing that's involved. And in fact, you can obtain a diagnosis without even having what it's named after, which is polycystic ovaries, polycystic ovarian syndrome. You don't have to have polycystic ovaries to obtain the diagnosis. So I don't know that it's becoming more common and that's why we're seeing more of it, or if I think there's a piece that is our lifestyles are leading to the expression of it. I also think increased awareness and people learning how to advocate and ask for more tests and push buttons, and ruffle some feathers so that they can get answers, because we just don't want to settle for here's birth control and that's it.
Yeah. And is there a link too between PCOS and endometriosis?
There's not a direct link. One thing that happens with PCOS is because you're not ovulating, you are not making large amounts of progesterone. Women only make progesterone after they ovulate. It gets made by this little temporary endocrine organ that's in your ovaries it's called corpus luteum, and that's responsible for making progesterone after you ovulate. If you're not ovulating, you're not making it. And then you have this extreme long period of time where you're getting overexposure to a different hormone, estrogen. Endometriosis is extremely estrogenic in origin, meaning how the uterine lining kind of grows throughout the menstrual cycle is dependent on estrogen and progesterone. And when you have a lot of estrogen, you have a lot of like the bulk without the progesterone, which I like to think of like the estrogen's the bricks, the progesterone's the mortar that's holding them together. Without the progesterone, we have this like proliferation of uterine lining. Endometriosis specifically is where that lining starts growing outside of the uterus. And both PCOS and endometriosis also have higher levels of inflammatory markers within the body. With PCOS, some of that is related to insulin resistance. With endometriosis, there might be more of a genetic piece to it, but I have seen patients with both, but there's not like a direct line. With PCOS, you're at a slightly higher risk of endometriosis. And I think that some of the data is starting to look a little skewed because you cannot diagnose endometriosis without surgery. You can guess at it, but you can't diagnose it. So a lot of times doctors are going in to do endometriosis surgery, and it's almost like they're finding things because they're looking underneath the hood. Mm-hmm. So you're at a higher risk, but it's not like if you have PCOS, you probably have endometriosis too. There's not that direct of a correlation.
Mm-hmm. And outside of the idea that we're just getting better at diagnosing it, we're becoming more familiar with it, do you think there is something happening that is making this become more prevalent?
I do.
And what are those things?
Yeah. So if I had to guess, because I've read so much of the research and I've seen so many of the clients, and I think a lot of times I want to handle this information really carefully in a sensitive way, because people often think of women with PCOS as being lazy and fat. And having worked with thousands of women with PCOS, there could be nothing further from the truth. It's like I often talk with clients and they're like, man, my girlfriend and I can eat the same thing and do the same workouts and she loses weight and I gain. And so there is a genetic expression involved. There's hormonal expression involved. So there's a lot of pieces, but having said that, and with a huge exclaimer that I'm not about to blame your PCOS diagnosis on what you've eaten your whole life. Generally, insulin resistance is rampant and very extreme in a PCOS body. And if we combine a propensity for being more insulin resistant, so somebody that when they eat, their body has to make more and more insulin to tell the cells take in the energy that's in your blood, the blood sugar, and bring it down to a good level. If those cells stop listening and they're having a hard time getting that message, you have high levels of blood sugar. Well, that increases inflammation. That higher level of blood sugar means more and more insulin. One of the only organs in your body that does not become insulin resistant is your ovaries. So in women that have high exposure to insulin, we have these ovaries that are like, what a party, like give me all the energy because it's there. They're like, open the doors, let the party in, and as soon as all that sugar comes in, it creates a perfect storm for things that we already struggle with. Women with PCOS have lower levels of antioxidants in their ovaries. Women with PCOS overconvert certain vitamins in their ovaries, which increase their ability to make testosterone. So as we see chronic disease and metabolic syndrome and insulin resistance and diabetes increasing in our population worldwide, not just in America, we are seeing increases in diagnosis of PCOS because they kind of can go hand in hand. Now, it's not a straight line because if you have insulin resistance, there are so many people with insulin resistance that don't have PCOS, right? But those dietary and lifestyle behaviors that increase your insulin resistance will kind of tee you up if you're genetically kind of like pushed towards that side of the equation. You're likely to have PCOS. We give it a perfect storm and then we're expressing those genes. We're saying like, hey, in millennia past, this was an advantage for us. We could take energy when it was plentiful and store it for later. We had more testosterone in our bodies, so we could build stronger muscles, more like men. Like there were advantages to this. Fast forward to our modern world where, I made pasta a couple weeks ago. It took me like an hour to knead the dough. You're going to eat pasta in Italy 100 years ago. The work it took to make that pasta was very different than boiling water and throwing some noodles that have been shelf stable for 2 years in water and then eat a large amount of that because we're also not eating enough protein or fiber to go along it to feel full. Like think about how much ramen noodles you can eat to feel full versus how much steak you can eat to feel full or how much broccoli you can eat to feel full. The type of food that you're going to get there requires so much less work and is so easy for your body to chop up and turn into blood sugar. We kind of create a scenario where it's really easy to become insulin resistant and kind of turn on these genes.
Yeah, I had a mentor before that always said, genetics loads the barrel, environment and habits pull the trigger.
Exactly.
So some of us might be more exposed to this potential happening, but then sounds like there are some actions and behaviors that we can take to maybe not have this happen or be so severe for individuals.
Yeah. And I would say another piece of the puzzle is stress. Stress also increases insulin resistance. Stress impacts what we choose to eat. Stress typically decreases our quality of sleep or length of sleep. And for me, I put a large amount of stress on my body trying to train for a marathon. And what was going on, now that I look back, I can explain it all. Like hormonally, what was going on and what I was doing to my adrenal glands, there's a piece of that that's kind of intermixed with a PCOS diagnosis. And sometimes you'll hear of somebody that has quote unquote lean PCOS. They don't struggle with as much of the metabolic burden, but their body is pumping out so much cortisol. And your adrenals are also responsible for making an androgen hormone, what we call a male hormone, but women make it too, and men make estrogen. So we kind of need to throw those things out the window. But you make an androgen called DHE, and then we sulfate it. We call it DHEAS. DHEAS is something your body uses to protect your brain from cortisol. So high levels of stress in women can yield a higher output of this hormone that can be readily turned into DHT and testosterone, very powerful, potent forms of androgens that in levels that for myself turn on things in my body I don't want turned on. It turns on me growing a beard. It turns on my hair falling out. It turns off ovulation, putting at risk my ability to get pregnant in the wild, I like to say. So it turns my body, it kind of tees me up to need more support, where if I could look at that stress bucket and say, maybe we just spend less money and we don't have that financial stress. And maybe we move to a role in my job where I'm maybe not running for the next promotion, but I sleep well at night. These are hard decisions. They cut at how society may look at you and think about you, but may actually be in your best interest. So it's not just insulin resistance. And I think that in the nutrition world, it's really easy to we all want an answer. And so we want to say, well, if we just fix insulin resistance, it'll all go away. The truth of the matter is PCOS doesn't have a cure. And you can manage it and almost go into what I would consider like a symptom remission. But as soon as stress rears its ugly head, as soon as you stop exercising the way that helped you, or you stop eating the way that helped you, it's going to come right back. It doesn't go away.
Yeah. And as someone that is a male that doesn't have PCOS, like even I trained for a half marathon last year and I gained 6 pounds. And looking back, I was like, I think my body was just so stressed from those long runs I was taking that I was not used to and really that well trained for, and didn't have the foundation that it threw my body for a loop. Like I was still strength training, I was running, and I was still getting fatter. I lost muscle and gained fat. And
so frustrating, right? And it doesn't, this is my big beef with the diet world. It doesn't make sense in this simple equation we all talk about, calories in and calories out. For people with hormonal and endocrine abnormalities, that equation doesn't work. Because as soon as your body sees a mega output of energy, like running 8 miles at once, it's going to say, turn all these body processes onto a more efficient role, because we're asking more of our body than we typically get out of our body. And so we actually see very often metabolic kind of inefficiencies. That's not the right. We become more efficient metabolically, but we're tired, we're cranky, and we gain weight because we've kind of shifted our metabolism down. And we're almost like loading the wrong thing. If you want to improve your metabolism, we need to work on probably exactly what you preach all the time, which is lean muscle mass, building more muscle mass, and improving the efficiency of how we use energy, kind of that metabolic flexibility. And by and large, that's not what women want to do. There's a shift in that. I think we've seen it in my adult lifetime, where it used to be aerobics that I watched my mom do, and now kids are watching their moms do something more like CrossFit. But it's for a lot of people, especially the population that walks into a gym looking bigger than the other people and more self-conscious and self-aware, they don't want to go stand next to this like burly hot guy lifting weights, grunting, and they're like, don't even know how to do a bench press. You know, it's like, it's so intimidating. It's hard for that person to even get going.
Yeah. And from your standpoint too, of looking at nutrition as part of this, right? Because we have a lot of active people that might be dealing with this stuff. So if you are a runner, or you're putting, high loads, high demand on your body physically, is more calories and more nutrition going to necessarily help, or are these hormonal fluctuations from the stress we're putting on our body something that's just kind of is what it is, and we have to
adapt our choices
in our training to like what we can handle?
I think there is some level of both. You'll hear from people that do long distance running or long distance anything aerobic that what do you need to keep fueling? Carbs, right?
Mm-hmm.
Like you get that goo when you're running the marathon, you get the this, you get the that. And that's true. Like when you're running, when you're doing anything, you need blood sugar. If you don't eat food that can turn into it, your body will mobilize other things to turn into it. So that's not wrong. But I think that, looking at things and saying, what are my goals and what's my why? Am I running a half marathon or a marathon because there's this half marathon and my niece just, survived childhood cancer and they're doing it as a whatever? Like, it's a very different motivation than just like putting a bumper sticker on the back of your car that you finish this marathon, right?
Yeah.
We got to step back and look at ourselves holistically, and tying into your why is always really important. I'm sure you see this in training people that have been in a lot of pain. Getting out of pain is a huge why. Talking to a woman that the doctor told her you probably won't have children, who's not ovulating, I've never met a more motivated person, truly. And I love working with this population because when we do it right, I get a picture of a baby. It's a pretty big win. And when we do it right, they're feeling better in their body. They have more energy. They see their body work in a way that they want it to work, right? So there's gonna be for everyone a personal answer to that. What's your why? What's your goal? Not just what motivates you, but like, is your goal getting pregnant ready? I find this is a really hard thing for people. I treat infertility as well as PCOS, women who have infertility outside of PCOS. And sometimes their most fertile body is not their leanest body. It's not their skinniest. Sometimes the healthiest form of you is not the person that needs to spend 6 hours in the gym because you've let all your relationships go, right? So we need to think about it very holistically. There are things you can do with your diet to answer your question. I advocate with women with PCOS that we're really looking at macros. We're looking at higher protein. When we're looking at carbs, we're looking for carbs that have a good amount of fiber. That's not just to get to net carbs, though I do track that with some clients. It's important for hormone elimination. One of the ways that we get estrogen out of our body is our liver packages it up and throws it into our intestinal tract, and it binds to fiber and gets stooled out. You poop it out. So if we're not eating enough fiber and don't have regular healthy bowel movements, we're going to kind of have this backup of sludge of hormones that your colon is actually very capable of reabsorbing. Okay. So we're looking at macros. We're looking more holistically. We're sometimes adjusting what we're doing so that we can negotiate stuff in the kitchen. Like, I work with so many people that kill themselves at the gym 5 or 6 days a week, but asking them to spend an hour and a half grocery shopping and meal prepping is too much. And I say to them, you can go kill yourself and do everything physically, but if we don't adjust the inputs, what your body's turning this energy into and how it can do that more efficiently, we're going to be in trouble. You can't out exercise a terrible diet. You just can't.
No, not at all.
And your hormones are made from the things that you eat. So that's critical. We have to kind of look at that when we're trying to fix a hormonal condition.
Yeah. I think the other thing too with it, from just a working out perspective, is like, I had this as a shower thought the other day, but I've been on this new program working with a new coach, and I'm working out less than I ever have, really, as far as strength training. Like, my workouts aren't as long, they're not as intense, I don't feel as dead, I'm still eating the same, and I feel a lot better, and I'm seeing like my body start to change. I'm like, this is just an equation. Like, we don't have to feel that we're beat up all the time. Like, the science even shows that, there are certain ranges and volumes and things we need to do, and we should be within a certain window of time and duration to get results. And that's it. You don't need to do more and more and more. Sometimes that less is more. And
yeah, I mean, I also think about, I find low intensity cardio. Like most days I go for a 3-mile walk and then I lift. That is better for my body. I also have a Peloton downstairs because the first time I ever lost 60 pounds was I shifted off running and I did swimming. I trained for a little mini try. I did swimming, running, and biking. And in the biking, I actually gained a lot of muscle in my legs because we were doing resistance. And I get a specific type of high, feel-good, endorphin thing from cycling that I don't get from any other form of exercise. And so mentally, I like to keep that part of my routine. Even though I know my PCOS responds to something different, my PCOS is not what defines me, and it's not the only thing about me. So I think, again, working with somebody that can help you kind of see the low-hanging fruit, first of all, and deal with that so that you can see some big wins off of small amounts of effort. And understands the bigger picture of what's going on inside of your body can be an incredible game changer because you're not wasting your time doing this one activity over here that's really not going to move the dial for you. And I think that this message is getting out to people, especially women who are kind of shifting. We're seeing the shift that strength training is important. It's going to be important. Do it now or wait till you're in perimenopause and you realize insulin resistance gets worse then. And that's what you're going to need to do to maintain your weight and still be able to eat food that you want to eat and drink wine if you want to drink wine. Like, you're going to need to do strength training then if you want the type of body you're typically asking for. So you could either get really good at it now and improve your bone health long term and improve your heart health long term and improve all these other things long term, or you could wait until you have no other choice. But I would advocate that we start implementing strength training and deal with body mechanics and functional movement so that, because I work with people that want to get pregnant. Like, here, I make big babies. My husband's big. He's 6'4", looks like a linebacker on a football team. My 7-year-old looks like she's 10. My 5-year-old looks like she's 8. And my 3-year-old is mistaken for a kindergartner most days. I went to the zoo with them a few weeks ago, and my 50-pound 5-year-old wanted me to give her a piggyback while I'm carrying my 35-pound 3-year-old on the front because I didn't bring a stroller that day. And you know what? I walked like a mile that way. But I could not have done that had I not invested in strength training. And so it's not just about how you look. It's about what you're capable of and meeting life's demands. Something that I'm trying to think about is balance training, because I don't want to be 80 falling over. And so what can I do, even though it's not sexy, like jumping and doing different things so that my muscles know how to handle me if I'm going to go down. Right. Yeah.
We can talk about that after the show if you want.
Okay.
I'll come on your podcast and we can talk about that. So one of the big things I want to get into here, dealing with either your PCP, your OBGYN, whatever the case may be. I am someone in my field, I see general medicine as it has its place, but we're not doing a good job at managing patients. People are getting brushed off all the time. We're not doing enough diagnostic workup to see what's actually going on, what is the root cause of this. And we're, slapping Band-Aids on with maybe birth control or something else. So someone suspects they have this, they go to the doctor. What do they need to know? What do they need to look out for? What should that doctor be doing?
How can they advocate for that themselves? Yeah. Okay. So I'm going to go back and give kind of a Reader's Digest, if you're old enough to know that term.
Yes.
Overview of what is the diagnostic criteria currently, because it actually just changed a couple years ago. So we're looking at in irregular or lack of ovulation. We call that oligo-ovulation or anovulation. Typically, that's like you're having less than 8 periods a year. That's a pretty big sign of that. That's hard to tell if you've been on some sort of hormonal contraceptive. So we look at other things too. But the doctor may even ask, can you remember back to before you went on birth control? What were your cycles like then? And they're kind of gathering data. The next thing that they'll look at is blood work. So they're going to look for evidence of high androgen levels. So they're looking at testosterone and free testosterone, so a total T and a free T. They're looking at, sometimes if they're thorough and understand what the science says, DHEAS. Very often they just look at total and free testosterone. They do some math on what we, there's kind of like a mathy thing you can do for an androgen index score that's not as important as just looking at these numbers on their own. Sometimes doctors will also look at A1C levels, which is a snapshot of like 3-month picture of what your blood sugar is doing. If they're awesome doctors, they will also look at something called SHBG, sex hormone binding globulin. I would recommend you ask for that if you are going in for a workup, because it's not as kind of normal across the board. Sex hormone binding globulin you make in your liver, and it does exactly what it's named. It goes around and it attaches itself to sex hormones and it kind of turns them off. So think about like having a key. If we chewed some gum and put gum on your key and you went to your front door and tried to put it in, it wouldn't work. That's kind of, the gum is the sex hormone binding globulin. So while the hormone may be there, it's kind of turned off. So that's the difference between total testosterone and free testosterone. Total has something like sex hormone binding globulin attached to it, can't do its job. Free testosterone can go around and it's free to go touch your chin hair follicle and say, grow a dark, thick one instead of this light peach fuzzy one. So that one's really helpful. If you see that you have low sex hormone binding globulin and higher free testosterone, we have an androgen issue, even if you don't get a PCOS diagnosis, and it's something we can look at and impact. And then the last piece is this ultrasound. This is what's kind of changed in the last few years. There is what we would call in medicine a surrogate marker. So a marker that kind of gives us an idea of what's going on. We can look at it in place of the other. And it's called AMH. It's called anti-Müllerian hormone. And it's a hormone that your follicles make in your ovary as they're kind of maturing. The more follicles you have, the more hormone you'll have. So the idea is that if you have a high level of AMH, we can deduce pretty clearly that you probably have extra follicles that are stuck maturing in their process, leading to what we would typically call a polycystic ovary. So it's nice because it's like a $6 lab instead of a procedure where you're being, I don't know, it feels kind of like you're being violated almost. And if it's not necessary, like great, it's less expensive to pull this lab. They're running blood work anyway. That's great. You need 2 of these 3 things. So signs of hyperandrogenism, irregular cycles, or signs of hyperandrogenism and polycystic ovaries. Or you like can have polycystic ovaries and irregular cycles. It's just 2 of the 3. Some of us are really awesome and get an A and have all 3 of the 3. That's me. Doctors will also typically look at things that are not a part of the diagnostic criteria, things like the A1C or fasting blood glucose. I applaud doctors that do that. They typically don't pull a piece of the puzzle in terms of lab work that kind of closes this loop or the circle and helps you actually make decisions off of it. So if you're going in for this diagnostic workup, I would also, in addition to asking for a fasting glucose and a fasting A1C, I would also ask for a fasting insulin. That insulin allows us to calculate something called the HOMA-IR score. It's essentially kind of like a BMI. It's not a perfect index, but it's an index, and it gives us an idea of how insulin resistant you are. So if we have your fasting blood glucose, we can kind of answer a question of how much insulin did it take to get to this level? Because by and large, most people with PCOS are still going to have a normal fasting blood sugar and even a normal A1C, even though they're severely insulin resistant and marching along a path towards diabetes. But it's not that bad yet. So the doctor may say, oh, well, your blood sugar isn't high. Let's not treat the insulin resistance with metformin. And they don't give you that option, where it might be indicated and not a bad choice to consider because they're just not kind of uncovering enough of the information to make informed recommendations. So I like to look at things in buckets. And I have, if you want me to, I can send over to you a link if you want a list of what these labs are to ask for your doctor.
Yeah, that'd be great.
I like to look in the androgen bucket, DHEAS, testosterone, free testosterone, sex hormone binding globulin. That helps us answer the question of high androgens or not. It's also helpful for them to pull a progesterone to see what part of your cycle that we're in, if you've ovulated or not. That can help us also answer the question of maybe if you're ovulating. It's not conclusive because it's just one point in time and we could have caught you before ovulation. I also like to ask for insulin resistant labs, so A1C, fasting glucose, fasting insulin, in kind of the same, just checking on health things that are usually comorbidities or something that we see diagnosed alongside of PCOS, something like fatty liver disease. So I want to look at liver enzymes. That's part of a metabolic panel you'll get typically annually with your primary doctor called a CMP, a comprehensive metabolic panel. And then another really helpful lab with PCOS, especially if we're like, does she have it? Does she not? We're kind of in this in between. We're not sure, is actually looking at ferritin. It's your storage form of iron. And if you have really low ferritin, that usually shows us that there's some sort of inflammatory process going on. So I like to look at ferritin and HSCRP and homocysteine to look at kind of a snapshot of inflammation markers in your body. So those are things I like to ask for. Will your doctor order them all? No. And typically there are two reasons they'll say they won't. One is, oh, this list is so long, it's going to be so expensive. That is not their problem. If you want to know those things, they're not paying for it. You're paying for it. You and your insurance are working that out. So you can say to them, the monetary investment is not as much of a concern for me. I would like a thorough hormone and health panel to help me make informed choices about how I'm going to manage this condition. If they... Sorry, go ahead.
The other thing I'd like to add there too is a lot of times nowadays it's cheaper to just pay cash for your blood work than it is to, like, I use a functional medicine doctor. I did labs recently. I prepaid him $250. That was supposed to be all I paid. The lab had my insurance information and accidentally billed my insurance. I got a bill for $1,200. I was like, what the fuck? How did we just almost 5x the cost of this blood work? It's like, well, they just want to make money off it.
They do.
So always ask.
Yeah,
ask
I mean, let me get there. So most of your doctors won't do it, or there's a financial piece. And so go find somebody like me or a functional medicine doctor that can order the labs. It does depend. New York, New Jersey are harder to order in. There's like 4 states that are harder for even functional medicine doctors to order in because of the laws. But many states you can get access to with a doctor that has a diagnosis code tied to the lab order. And that's kind of the issue with New York, is you have to have an ordering physician within New York with a diagnosis code that's attached to it, yada, yada. I can't order there, but I can order almost anywhere else in America. The other thing that they're going to say is, like, it's not going to change how we intervene or how we're going to treat you. And that is typically true. And I would say probably the more beneficial reason for a doctor to say, I don't want to order this, because it's not going to change what I'm going to do. I can at least respect that, but it may change what you want to do. And that's enough of a reason as well to say, okay, well, I understand either way you're going to give me birth control and metformin, maybe another medicine called spironolactone, or maybe we're going to march into fertility medicines. But just because it won't change surgery or medication that you're going to offer me, I still want to look at this. Those are hard conversations to have. I had a conversation like this with the doctor yesterday because my dad has cancer and we're kind of fighting for more answers before we go into a really intense surgery. And I could tell every question I asked the doctor, like, literally rolled his eyes at me. But at the end of the day, he's a doctor. He's not my best friend. He's not who I'm going home and making out with at night. Like, I don't really care what he thinks of me. My dad is my primary concern, right? in this scenario, your health is more important than your doctor's ego. And if finances or it's not going to change your treatment plan is the objection, I would highly recommend, in any case, even if you don't have an objection, to find somebody in kind of the functional and integrative medicine world who will be much more apt to do a thorough blood draw for you and help you get the answers. And I run these labs all the time. And to Brett's point, I can run a lab for you that's prepaid, cash pay. We just pay Quest directly or LabCorp directly or whatever. Any lab test now, there's a number of different places you can typically go somewhere near you to get your bloods drawn. And it's $200 to $250 to do a very, very thorough look. My doctor pulled my vitamin D and they charged me $120. I can pull your vitamin D for $20. So sometimes I often just say, send this email to your doctor's nurse through the portal. If they don't want to pull it or they balk at it, let's just do it on our own and you just pay cash because it's a little bit easier. What I will say is functional medicine doctors also love to throw on a lot of functional medicine testing, like stool testing, hair mineral analysis. In the female world, urine testing to look at hormone metabolites. And those things have their time and their place, but they are very expensive. And what I've found in practice, I'm trained in functional medicine, is they don't often change the first 6 visits of things that we're going to work on. So let's do the low-hanging fruit work, the work that's going to yield a lot of benefits. And then if we need to test, let's test your body then to see what we're dealing with. Because right now, I can almost tell you what it's going to say based on your GI symptoms or based on your hormone symptoms. I know if you're presenting this way, we have these issues. It's nice to have your insulin and your blood sugar so we can see your home IR, and then in 3 months retest it and you see it cut in half. And that is something that will help you stay motivated and moving forward. But it's probably not going to change the diet advice I give you or the supplements I'm going to recommend. And so even in a case where you can't get a hold of all the testing, or even if you'd rather say, I want to spend $250 hiring a personal trainer and buying some supplements this month, I'm all for that too. And let's do the things we know will move the needle for you, and we'll test when it seems appropriate.
As far as the insulin resistance goes, because that seems to be a thing a lot of people are talking about, not just with PCOS, but a lot of other chronic disease states and autoimmune issues coming up. What can people do about insulin resistance, and how do they become more sensitive to insulin?
Yeah, there's lots of ways. I'm going to end with diet, even though I think it's probably arguably in the top 2 or 3 reasons you can impact, or top 2 or 3 ways you can impact more directly. But we'll end there because that's probably my biggest soapbox. Movement is a huge one. We can see any type of movement within 3 weeks improving insulin resistance. So if you're doing nothing right now, getting out and going for a walk is going to help. We see huge strides in people that are willing to do strength training. But any type of movement, especially if you can enjoy it and sustain it, is better than no movement. When you're moving your body, your muscles are responding more quickly to insulin. And so that tells your body, we don't have to make as much insulin to get this job done of getting the blood sugar, the sugar in the blood from the blood into the cell, thereby lowering blood sugar. So it just increases your body's understanding of its own efficiency or sensitivity to insulin. We want to increase sensitivity. We want your body to see insulin and go, I know what to do with that. Instead of that neighbor boy just keeps ringing the doorbell. I'm just not even getting up anymore. That's what an insulin resistant cell is going to do. It's going to be like, I don't want the messenger. Don't send it. So movement is a huge piece. Stress management is also important. I would argue probably sleep quality is up there in some of the top things that you can do. We have medications that can help and insert like really popular stuff right now. Metformin's been around forever, but GLP-1 receptor agonists like Ozempic, Wegovy, Mounjaro, those help with insulin resistance. It's one of the ways that they work so effectively.
Don't those affect fertility though too?
So, well,
or suspected maybe
they can improve a condition like PCOS because we're so struggling with high levels of insulin. We see a trickle down effect.
Okay.
So it can go either way. You should not be actively trying to conceive on these medications. So there's something that you have to kind of wean yourself off of, and they're a long-term plan versus like, I'm trying to get pregnant already. That's not something we're going to put you on. I think the official kind of recommendation with them is a 3-month washout period. So you have to be off them completely for 3 months before you start trying to conceive. I would argue as a fertility dietitian that you may even need longer, particularly if they worked by really decreasing your appetite and really decreasing your intake. Oftentimes people can get away with actually eating worse on them and eating less. And so your nutrient stores are really getting depleted. And that's not how you're growing a human inside of you.
Yeah.
That's not how you want to start that process. It will be bad for your baby. It will be bad for you. So I would really work with somebody that knows how to help you replete those things if you're coming off of one of these medications, hoping to move into a season of trying to conceive. But those are very effective at improving insulin resistance. So I'm not going to only tell you what I recommend, or I want people to be informed, and then you take this information and work with your practitioner to make the best decision about your health, your goals. They do work. They're helpful with insulin resistance. They have some really long-term downsides, like most people that go off them stop realizing the benefits of them and then gain it all back like any diet they ever did. So they're not just like this is the solution. Everything needs to be paired with diet and lifestyle. And you can take those medicines and do it really wrong and end up in a much worse place. Or you can take those medicines and have support and do it well-ish and have a chance at maintaining whatever benefits you realized while being on the medication. To that effect, we also have supplements. And in the supplement world, we have a couple really big heavy hitters that improve insulin resistance. Ones that come to mind are inositol, N-acetylcysteine, or we call it NAC very often, and berberine. Berberine, we see a lot more research in the type 2 diabetes and prediabetes world, but I extrapolate that very easily to the PCOS world and see lots of benefit, especially if you're somebody that's like, I want the more natural option versus the pharmaceutical option. Berberine and metformin go head to head in a lot of studies. So those are a couple that come to mind for insulin resistance. Cinnamon, though, in the nutrition piece, but you can also take it as a supplement, can be helpful. And we could do a whole podcast on insulin sensitizers in the supplement and herbalism world, but
that would be so cool.
Those are the 3 heavy hitters. Berberine, inositol, and N-acetylcysteine. Inositol and N-acetylcysteine, if you're listening to this and you're trying to conceive, have a lot of benefits for improving egg quality as well and decreasing the time to ovulation, which when you're trying to get pregnant, if you're ovulating 4 times a year instead of 12, you've got 4 chances to get pregnant instead of 12. And so one of the frustrating things about PCOS is this irregular cycle or less ovulation oftentimes translates to you're just getting less opportunities. And it's not like they all told us in high school, health class. Like there are 5 days in a woman's cycle she can get pregnant. and it's the day of ovulation pretty much in the 4 days prior. After she ovulates, that egg has 12 to 24 hours to meet sperm and become inseminated, or it dies. It like kind of shrivels back. So sex timing for women with PCOS and kind of cycle literacy, understanding the signs that your body's trying to ovulate, it's about to ovulate, it did ovulate, and improving timed intercourse is a huge piece to decreasing the amount of time to get pregnant. So I love those 3 specific supplements because they kind of overlap. If we can kind of fix 2 things at once, why not? And those supplements are really great in that effect. But as a dietitian, if I didn't bring up how you eat matters, none of all the other things would be very good to you. High protein intake, that's typically one of the first things that I focus on. Protein not only helps kind of limit how quick your blood sugar rises when you're eating it in the context of a meal. It also increases your metabolism, whereas large amounts of carbohydrates can actually slow down your metabolism. So your macronutrient, when I say that, if you don't know what that means, listeners, fat, protein, and carbohydrates, and then alcohol is kind of the last macronutrient that we don't typically talk about. We're talking about adjusting how much protein, how much fat, how much carb is on the plate at any particular meal or snack time. If we can increase protein compared to carbohydrates, we can do a lot of work in terms of helping you balance your blood sugar and becoming more insulin sensitive or less insulin resistant. So I typically give women a goal of 30 to 40 grams of protein per meal as a good starting point. If they don't have a disordered eating history, I like to have them track their food for 2 or 3 days of like maybe 2 days during the week, typical eating, a weekend day, and look at it meal and snack by meal and snack and say, in this meal, not the totals for the day, but in this meal, how much protein was there and how much net carb was there, the total carb minus the fiber. If I can get the net carb lower than the protein, that's a really good combination for a PCOS body to start making strides to lowering insulin resistance. And so that's kind of a typical goal. I also really like to focus on starting your day with savory foods instead of sweet foods because it kind of trains your palate for the day. If you start with a sweet breakfast, you're more likely to want a sweet thing in the afternoon. If you start with like eggs and sausage and some avocado, you will be less likely to crave that sweet. So it's not even just what's on the plate in terms of macronutrients, but finding those simple switches that can be kind of heavy hitters in terms of beating your own biology. If you eat sweets, you're going to crave sweets. It's the way we were made. If you found the berry bush, you were meant to stay there and eat it until there were no more berries left because berry bushes are limited, right? So it's a biological drive, and we want to work understanding those. It doesn't mean you can never have a sweet breakfast, but by and large, most breakfasts should be savory if you want to make it easier for you not to crave sweets throughout the day. So kind of understanding macronutrients and shifting more towards protein. Fat is kind of neutral in the sense of it doesn't raise your blood sugar. It can actually slow how quickly your blood sugar raises because it slows how fast your stomach empties. And so there's benefits there, which are great. I often don't even really have people focus on fat because I find if we can deal with the protein and the carb piece of the plate and we're increasing like their exposure to brightly colored foods, the fat kind of takes care of itself and people can kind of step away from feeling like they need to track all the things, including calories, and just focus on, honestly, like if you make a breakfast, if the eggs and the sausage looks bigger than your one piece of sourdough toast, it's probably pretty well macronutrient balanced, and you don't need to live in the weeds of MyFitnessPal for the rest of your life.
I nailed my breakfast this morning then.
Yes.
Not going to have PCOS.
You're not going to have it.
Literally had eggs, bacon, and one piece of sourdough. So, yeah.
Dietitian approved.
Yep.
This is one thing about dietitians. when people meet us, they typically confess what they ate for breakfast. It's like, oh, what do you do? Oh, I'm a dietitian. They're like, oh my God, I had a donut this morning.
Yeah.
And I'm like, great. Was it tasty? It's like, I'm not your food priest. I'm not going to like,
Yeah.
I don't have anything to absolve you of that. Like, good. I hope if you had it, you enjoyed it, you know? Or the other thing is then they're just like, it's like a free pass to ask any diet question you've ever wondered.
Yep.
What's it like as a PT? What do people, when they meet Dr.
Fix
Scott?
Fix it.
Yeah.
Fix this elbow. My elbow hurts. What do I do? Do something for it right now. It's like, well, okay, we're at a bar. I need like 45 minutes to diagnose this.
Yeah.
Or as a coach, it's, oh, can you put me on a training program? Or I'm going to tell you all about my struggles with weight loss. And then I'm going to ask you questions and not listen to you at all.
Yeah.
So I just, half the time I go out now, I just want to tell people I'm like an accountant or something.
You should actually. You should. Yeah. You should just say I'm a content creator.
Yeah, maybe I'll start doing that. And then, so with the carbs too, in insulin resistance, is it just relatively better to have lower carbs? Because I've heard things too of the keto diet could potentially reverse symptoms of PCOS in 12 weeks.
Yeah, there's a lot of that. I mean, I think that the two biggest questions when it comes to improving insulin resistance that are kind of buzzy right now, for good reason, I will say, is keto and intermittent fasting.
Yep.
You can improve your insulin resistance and live with very well managed PCOS without having to go into ketosis and remain in ketosis. That's what the ketogenic diet does. Does that mean that the ketogenic diet couldn't have benefits? It could. It actually, I would venture to say it does, but it also has drawbacks. And this is, again, one of those times where you want to zoom back and look at the whole person you're treating.
Yeah.
Do you want to be that person that can never have cake at the birthday party? Or, you know, like, it's like...
It's not sustainable for a lot of people.
So in my world, if a diet doesn't check the sustainability box, and so what that means to me is if you can't start eating this way and eat this way forever, not for the next year while I lose 50 pounds, forever. Any diet that's going to get you to somewhere, as soon as you stop doing that diet, you're likely going to lose some, if not all, of the benefits of it. And that includes calorie restriction. Calorie restriction done improperly will leave you with a much lower metabolism and set you up to have weight struggles for the rest of your life. Like, you have to do some pretty strong metabolic retraining to get out of what I see a lot of women do to themselves, eating like 1,200 calories or less for years, going on and off, on and off, on and off. So the ketogenic diet, essentially we're eating large amounts of fat, a good amount of protein typically, and like depending on what you're following and if you're doing it with like strips that are telling you whether you're staying in ketosis or not, we're eating really low net carb, like usually under 30 grams net carb total for the day. So to me, that leaves out most fruit, that leaves out most vegetables, most fiber containing foods. At my academy, which I don't belong to because I don't believe in what they teach, would tell you that you could not be healthy without those things. I think that that's not true. I think you can be healthy on a keto diet, but you have to do it like perfectly. You have to do it perfectly. And most of us won't do that either. I don't love a keto diet for somebody who's trying to improve their health so that they can get pregnant. I don't love a keto diet for somebody who's regularly menstruating. So a woman in her fertile years, I think there's arguments to be less strict, but learn what we can from the keto diet. Eating less carbs does impact your blood sugar. And so that can be really helpful, but you don't have to go into ketosis to have better blood sugar. Ketosis works for what people want it to work for because it's inefficient. you turn to fat for calories and turn fat into carbohydrate in your body because you're not eating carbohydrate. And that's inefficient. You burn more than what you receive from the calories from it. And so you slowly, over time, lose weight. But it doesn't check the sustainability box. And for that reason alone, it's just not my favorite. I know a lot of people that do it and enjoy it and feel better on it. So I'm not going to discount that. That's just as important as what the science says. If you're doing it and you feel good and your labs are good and you have more energy and you've found a way to eat enough fiber and you're happy, who am I to tell you not to do it? But it doesn't work by and large for most people. And women with PCOS have higher incidence of eating disorders, particularly binge eating disorders. And so when we go into these like restrictive style diets where things are crazy off limits, we just create a cycle of, I did really good. Okay, now I'm going to reward myself. With ketosis, there's no room for that. You reward yourself, you pull yourself out of ketosis, and you have just lost the benefit of the inefficiency. And now everything else you're going to eat is going to be basically stored as fat because your body's like, well, we got to rebuild this store up for us. So, and once you binge, you tend to be that person that's like, well, I already fucked it up. I already ate a sleeve of Oreos, so I might as well just ... Mm-hmm. So I don't love that. I think the next logical question then is, what can we learn from it and apply from it that's helpful? And I think the answer to that is the standard American diet is so high in highly processed carbohydrates, and that's become so normal. Think about, if you're going to make a cheap dinner for dinner, it's like spaghetti with red sauce, basically all carbs. Where's the meatball? Where's the bolognese? Where's the fiber on the side? We're using typically white flour. So how could you turn that around to be a healthier meal? Okay, so the applicable side of this. Let's get a garbanzo bean-based pasta or something that's higher in fiber, a little higher in protein, or at the very least a whole wheat pasta so we get a little bit more fiber, a little bit more protein. Let's add some meat to this equation. And then let's roast some asparagus on the side and make half your plate asparagus and a quarter of your plate the noodles and a quarter of your plate the meatballs or whatever the protein source is. That's how we need to kind of start looking at our plates to manage the insulin resistance. But it doesn't have to be no pasta at all. I'm a huge proponent. We do pizza night once a week at my house. We did it last night. It's usually Friday night. I did it last night. And we do it typically after a meal that we do like a lean protein. So I grill up a lot of extra steak so that on a pizza night, I have a piece of pizza with some steak from the night before and a huge salad. I'm still getting half my plate vegetables. I'm still getting the carb and enjoying the food, but I'm also modeling to my children, you can eat pizza and still love your vegetables and still want protein so that you feel strong. It's the terminology around it too that I think matters. I think intermittent fasting, people are like, this is the cure, right? We know it improves insulin resistance. Like if somebody were to argue that it doesn't, don't listen to them. It does. It does improve insulin resistance. You literally don't eat. And so your body doesn't have to make insulin to bring your blood sugar down to the degree it would when you're eating. It does make it while you're sleeping, for instance, but it's making it in very small amounts because you're grabbing blood sugar from your liver and from your muscles while you're fasting. So it's not the same as like I just ate a bagel at Starbucks and a vanilla latte where it's like this huge surge. Yes. So you have this longer swath of time that you're fasting and your body goes, we don't need to make as much insulin. And so there's less insulin. Insulin becomes a problem because it doesn't just impact this metabolic piece in the ovary with PCOS. It also is a growth hormone and signals to your body to store things. Okay. So more insulin means more fat. Try to eat low calorie and only eat carbs and lose weight. It's very hard to do because we're trying to override a hormone sending a message in your body to store fat. It's going to be very inefficient for your body. So kind of pulling what we can from keto and pulling what we can from intermittent fasting, do you have to, like the most common form of intermittent fasting that I see is like a 16-8, where you're fasting 16 hours and you eat 8 hours. Okay. That's not a crazy thought to me, but the hours that people are typically eating, that's the crazy part to me. You will be your most fertile if your biggest meal of the day is breakfast. Like we see that in research. Bigger breakfast, the better. So if you're going to do a 16-8, move that 8-hour window to where you're eating a big breakfast and lunch and you have like a, like you eat breakfast at 8. Okay, let's move forward 4 hours. Now it's lunchtime, it's noon. Let's move forward 4 hours. Last snack happens by 4 p.m. What that fucks up in America is we're all working super late. The time we commune with our families is dinner, and we want to Netflix and binge at night and just eat popcorn or spicy Cheetos and have ice cream. It doesn't coincide great with our culture, but probably that's how most of our ancestors ate, was more like longer fasting periods because food was harder to come by and you had to hunt and there had to be gathering. And as soon as the sun went down, you were like sitting by the fire and then getting cozy. So people that are so anti-intermittent fasting, I have issue with that because we can learn from it and we don't have to be so strict with it to realize the benefits. Because most people wake up and start pounding coffee at 6 to 7 a.m. and then they have breakfast and then they have lunch and then they have a snack and then they have dinner and then they have drinks and dessert. And we have a eating window between 6 a.m. and sometimes like midnight. Mm-hmm. So you have a 6-hour fast. We've just flipped the script on how much you're making insulin. So 16-8, unattainable for a lot of people. But what about like 12-12? What if you don't eat before 7 a.m. and you don't eat after 7 p.m.? What if right now your last something happens at 10 p.m.? Well, for the next week, let's try and make that happen by 9 p.m. And then for the next week, let's make that happen by 8 p.m. And then for the next week, we don't have to make these extreme shifts that change so much of our day that we can only sustain it for a few days and then we fall off the wagon and fail again. So extending that overnight fasting window can be beneficial without going super hard, like on a 8-hour eating window. It's not just about the insulin. It's also about what you ask of your body. When are you working out? When are you sleeping? Are you a nursing mom? Like there's so much more to it than just that. Yeah. That it really requires an expert to help you get rid of your pain or to look at the whole ecosystem of your life and say what you're about to do with this extreme diet that seems to be the answer because it's the only thing you haven't tried is actually going to fuck you up. And why don't we take what we can from all of this and create a sustainable plan for Jane PCOS?
Yeah. And what about the longer term fast too, or doing, the different forms? Because like I was
like a 2-day a week that you don't fast at all, that you don't eat at all.
Yeah. Something like that. Cause I've even been thinking of that just from I was talking to my girlfriend yesterday about this, of just like the psychology of food and our thoughts on, appetite versus true hunger. And like a lot of us just eat because we've been socially taught to eat breakfast, lunch, dinner, dessert, snacks, whatever. And like it is okay for our body to go with prolonged period of time once in a while without food, and we're not going to die.
We actually see longevity benefits to fasting.
Yeah, there's like a lot of stuff I've heard coming out with like a 3-day fast will like kill like 50% of like precancerous cells or something.
Yeah, it's true. I mean, you can't deny the research.
Yeah.
Again, is that how we want to live our lives all the time? Probably not. But think about Ramadan. You and I live in a primarily Christian country. You know when my Muslim patients tend to get pregnant?
When they're fasting?
Ramadan, or right after Ramadan, because they fast all day long and they only eat like early morning, late night. I don't know the exact.
Yeah, they have a window.
They have a window that they eat within, and they fast for long periods of time. And for my PCOS patients, they're having a whole month of daily fasting when they're asking more of their body in terms of movement. So their body should be taking in food, making insulin, and it's not. And somehow they pull it off. I mean, I'm Christian. There are reasons why we're told to fast. There are patterns of fasting in the Old Testament. We see Jesus fast for 40 days. It's possible. Totally possible, right? We see health benefits to it. Again, we have to contextualize though. If I had a patient coming to me saying, we're actively trying to conceive and I'm on fertility medications, this would not be the time I would say, let's fast, right? Yeah. So, but I agree with you. I think we should have broader conversations. I personally have entertained the idea of like, well, what if once or twice a year I do something like Prolong, where it's a fasting mimicking diet, where you do like soups and things that are higher fat and it's a lower calorie and it's not like you're not eating anything, but it mimics fasting in a very kind of controlled way, and realize those benefits. I mean, hey, I'm looking at my dad with cancer. I want to live a long time super healthfully with my children. And I, with a PCOS diagnosis, am more likely to have heart disease, strokes, fatty liver disease, uterine cancers, metabolic syndrome. Arguably, I might even have metabolic syndrome right now. Like, what can I do to stack the chips in my favor? Do I think that I should, on a podcast, say to everyone, go do a lot of fasting? No, because that, again, goes against my whole shtick that you're an individual with unique needs, unique history of food you love, unique capabilities in the kitchen, unique schedules. I hate when I hear people say, like, we all have the same 24 hours in the day. Yeah, go tell that to the lady who's cleaning houses and works 12-hour days and then has to get home and do homework with her kids and get them to school the next day. And I have more hours in my day of luxury, and I understand that. I didn't have to get up early to exercise today to still have an opportunity to exercise. That's a privilege that I have. We don't all have those same 24 hours. I love to cook. It's so fun for me to be in the kitchen cooking. Very different than somebody who's like the CEO of a company who, or even not, like, let's say less resources. Right now it's tax time. You're an accountant. You're working a 70-hour week. You don't have time to like make noodles from scratch like I did 2 weeks ago. That's crazy. Yep. So we have to really think about things. And this is where I think we really get it wrong with exercise and nutrition, is we try to make these huge changes overnight and set ourselves up for failure. I expect you to fail when you do that. And when you do, it's not a surprise to me. And so, but you're going, it's one more thing I didn't do well enough or have enough energy for, and I'm a failure. And it like breeds this shame cycle versus saying like, hey, can you, instead of eating your last snack at like 9:30, can we do that by 8:30 for the next few weeks? We'll train your appetite to not be hungry at 9:30.
Yeah.
It's gonna be uncomfortable though if we do it all at once.
Yeah. Yeah, my interesting, I was having this conversation the other day about the fasting thing with like eating early and then not, and like restricting later in the day of, there's such a social norm, but can we change it?
We totally could. I've been thinking about doing dinner at 4 because my kids come home from school hungry and then they eat snacks and then we get to dinner and they're not hungry. And our snacks are typically not as healthy as our meals in America, right? So like, why not just feed them dinner at 4, and if they're hungry at 7, give them a snack then?
Or like, why do we all like, yes, we forge together over dinner and that's our time of commune or whatever, but do we need food to do that?
No,
we
don't.
Sit at the table and have a conversation and bond over whatever things we're dealing with versus stuffing our face with pasta or steak or whatever. It's just an interesting thing that people are so shut off from thinking about or being open-minded about, I think. So just something interesting there. Do I have anything else? Oh, yes, birth control. Is birth control something that can make PCOS worse? Because now I see a lot of women too that are around my age that are getting off of birth control, and not because they're trying to become pregnant, just the ill effects and adverse effects of being on birth control, apparently.
Okay, so some big overarching bullet points. Birth control helps lower androgens, depending on, most of them do. Birth control, by and large, works by doing a few things. It turns off ovulation, so you're not maturing follicles, so you're not making your own estrogen. You're not ovulating, so you're not making your own progesterone. And so birth controls are typically made to mimic that with estrogen and progesterone-like substances, so that your body's like, oh, we see progesterone, we don't need to make it. In doing so, we lower or diminish your body, the ovary, the follicle within the ovary that's going to yield an egg is what makes most of the testosterone in your body, aside from what I said earlier with the DHEAS from your adrenal glands. So if we turn off follicles maturing, we turn off the androgen. So it is a very effective way to slow down or mitigate the effects of hirsutism, having male patterned hair growth, like the bearded lady type syndrome, hair loss. Acne is a huge complaint of a lot of women with PCOS, adult acne, that is driven by testosterone. So we can turn that down. And typically, birth control also raises sex hormone binding globulin. So whatever is there gets gobbled up more easily and kind of turned off. That is why doctors love to prescribe it, because it's effective. Gives you symptom relief. If you study birth control, it's so interesting. You don't actually have to have a bleed on a birth control. They just made it that way so that women didn't think it was like weird and bad for them. So it's very interesting. Women who have PCOS often ovulate less, and so they bleed irregularly. So you have this person who's like going about her day having no idea, going about her month, going about her year, having no idea when she's about to start bleeding. That can be frustrating. So there's a lot of reasons why people decide to go on it. There are things doctors don't provide good informed consent with when they're describing the risks versus the benefits. Oftentimes the risks that get brought up are things like your risk of stroke goes up, especially if you have a history of blood clotting issues in your family. They don't talk about how it lowers your libido. Don't talk about how it increases your risk of nutritional deficiencies. They don't talk about how it increases your risk of depression and anxiety. They don't. I've never had a patient tell me, my doctor brought up that my clitoris would probably shrink being on birth control. And a lot of us women got put on it when we were teens, when we didn't have an idea that that would matter with our sexual gratification and enjoyment through our lives. And so these are the things I wish people knew, because you still might make the decision that I'll roll the dice with my mental health, or I'll roll the dice with my stroke risk because I don't even want to leave my house most days because of how much facial hair I have. But that should be a patient choice, not this is your only option. And when you want to get pregnant, we have different medicines for that, because they do. And for a lot of people, they work. But the downsides of them need to be considered, and alternatives need to be offered if we're going to get true informed consent. An alternative to birth control to lower your acne could be as simple as drinking 2 cups of spearmint tea a day. So medication that's going to shrink my clitoris, drinking spearmint tea, I mean, if I could go back and make a different decision, I'd want a bigger clitoris all day long, right? So it's that piece of the puzzle is very frustrating. The other thing that probably frustrates me the most is that there's some research that shows women shouldn't be on birth control for more than 10 years cumulatively throughout their entire life. And when you go, you like change OBGYNs or you change your primary care and you say, these are the medicines I'm on, they're not often asking, how long have you been on this? They're not often talking about the exit plan. Anytime you're prescribed anything, a doctor should talk about the benefits, the risks, the alternatives. What if you do nothing? And if you decide to take this, how long you should be taking it. Okay. What is that duration? Birth control, you have a 10-year tops. I got put on birth control at 16. I didn't start having babies till in my 30s. If I had stayed on birth control all the way through there, it would have increased many risks for me going forward. I knew enough by the time I would have hit that 10-year mark to have decided to go off of it. But those are things people should hear. It is effective. The right types, not all types, treat PCOS as well as others. The right types are very effective at symptom suppression. However, it doesn't make your PCOS go away. It doesn't deal with the insulin resistant piece. It doesn't deal with a lot of these things. So people go on it and think, oh, my PCOS is so much better. And they haven't been referred out to a dietitian, or they haven't been told to make these lifestyle modifications to help improve their symptoms as well. So then they go off the pill 5 years later, 8 years later, 1 year later, and their PCOS has gotten so much worse. They just didn't have polycystic ovaries in that scenario, but they've created an environment that as soon as we suppress your own hormone production, when we stop doing that, things are wild. And it can take over a year to get your period back without any underlying conditions after going off of hormonal contraceptives. Doctors aren't talking about that. It's like, come back when you want to get pregnant. No, come back at least a year before you want to get pregnant, because we have some work we need to do to work on your hormones to get you to a place where you could potentially get pregnant. So those are things that I like to bring up. I think that there is a huge anti-birth control movement, and
yeah, what are the big reasons for it?
Okay, this would be my first. If you are a woman, if you have a vagina and you walk into a doctor's office with a complaint, the number one prescription is birth control. It doesn't matter what the complaint is. It's the solution for almost anything if you have ovaries. That's bullshit. We don't get as much testing. We're required to deal with more pain. I mean, you brought up endometriosis earlier. Doctors are not trying to find the root cause of the painful period and deal with that. They're just trying to deal with it with a small pill you can take every day. It's less expensive than surgery, gets you out of the office. I mean, something else that I think is really interesting, maybe outside of this conversation, but women are attracted to men differently, whether they're on the pill or not. And women are more attractive to men, whether they're on the pill or not. There's a study with strippers that are on hormonal birth control versus strippers that aren't make less tips.
What?
Pheromones, man. Hormones.
It's
Can't argue with science.
Crazy study someone came up with.
I love it though, because you got to find a way to say like, what's it doing, right? Like women are more attractive when they're not on birth control. You will be attracted to somebody that's more masculine when you're not on birth control. When you are on birth control, you're more likely to be attracted to men that display things that we would consider to be less masculine. This is like a conversation you have in this day and time, and everybody's going to come at me because I've been using male and female and men and women all conversation long. But that aside, the dude with the muscles is going to be more attractive to you when you're not on birth control. The one that can protect you is more attractive to you. The one that can like pick you up and have fun in the bedroom, more attractive to you when you're not on birth control. Crazy, right? Mm-hmm. So again, we could do a whole podcast on birth control alone. And that's not to say that it isn't a great solution in certain times. I love when I get clients who are like, I'm on it and I want to get off it. And we can spend 6 months or a year setting them up to come off it successfully versus I came off of it a month ago, shit's crazy. And like, I'm about to go back on it because I can't handle what life looks like. I'm like, go back on it and let's do the work.
Because it's a hormone. So like, I know with men that are doing testosterone replacement, like once you kind of go on that, you're kind of married to it. And if you come off, I know guys have tried to do it for fertility issues, whatever reasons, and they're like, it's horrible. But it's kind of normal coach, and like there's things men can do with that, of taking different medications to kind of turn their system back on. So many women are on birth control from the time they're like 14, 15, 16 now, and then they just go cold turkey 10 years later. It's like, I've been on this a long time. You can't you shouldn't just do that.
We wouldn't do it with any other medication. My dad, with his cancer treatment, he has AFib, and so he's on a medication that helps him because he has a high pulse, and like lost so much weight, needed less medicine. Now we're in between treatments, and his pulse has gone way back up. Like, we didn't stop at cold turkey. We went down and we looked, and then we went down again, and now we put it back on. We went up. That wasn't enough. Then we go up again. We do it in so many other areas of medicine.
Mm-hmm. Yeah, it's crazy.
If there was a medicine that could give you all the things you ever wanted, but it shrank your penis, would you take it?
No.
I wish somebody would have flat out said, the thing that will be one of the biggest pieces for you to reach orgasm is your clitoris. And if you take this medication, it will shrink. Would you rather take the medication or take some of these supplements? All day long, I would have said, I want good sex for my whole life. Right? Mm-hmm. This is not, it's not unattainable to have an orgasm on hormonal birth control. Your clitoris is not like completely damaged and dysfunctional. It sounds like a really crazy example, but like, it's something somebody should have said to me, and nobody did.
It's a bold statement too, to ask someone, but it makes you think. So
most women don't even know what a clitoris is at 16, and that's a whole different conversation.
Yeah, we'll save that one.
We'll save that one for another time. Barbell talks.
Yeah, you know what?
PCOS. You weren't sure you were going to hear about so much clit.
Yeah, I'll put that in the
show notes.
or even on social media, what we talked about today. But I've talked about this stuff with a lot of women. I've had a woman on that came on. Yeah, I had a woman that came on that talked about HRT for women, and like, she had a dry vagina. I've talked about all that stuff. I have a pelvic floor physical therapist come on talking about all the stuff with that.
I love that.
And yeah, we talk, and then like, I talk to my patients about some of these things sometimes, and they're like, it's just physical therapy. I thought we're supposed to like work my shoulder. It's like, well, maybe, but like, if you have all these systemic things going on, let's try to uncover them and see where we can get you put in the right direction of how to better manage these things. Because yeah, like PCOS too becomes something that, I mean, in a sense, it's an inflammatory disorder. And if you have low back pain, hip pain, pelvic pain, like, that stuff can all be referred from there. So can we manage the inflammation? Because I can't just like we can't out-train a poor diet, we can't out-rehab a bad diet either. So
totally. Right? Like, if I don't do the exercises in between my PT, or if I don't try to make the functional changes, like I have back and shoulder issues, you know, my PT has me doing these like
chin tucks. You should also get a head with or a chair with a headrest.
I should do a lot of things, man. I should do a lot of things. But what I'm saying is, like, I think a lot of people expect you and I to come in like a fairy godmother and wave a magic wand, and they want solutions. Like, I want to get pregnant now. I get that. Even with my background and all the things, it still took us 3 years to conceive our first child. Like, I've lived in fertility. I understand you want to have a baby now. But you also have to be reasonable that you've eaten and acted this way physically for the last 10 years. We're not going to fix it in 1 week. So you're going to have to put in work. Your posture has been what your posture has been to create this head forward referral issue. We got to do the work to realize the benefit. And I'm really clear about that with my patients. Like, I can tell you what to do, but if you don't go home and start trying to implement this, that nothing will change.
Yeah. Point blank. Anything else you wanted to add? I think that's kind of everything I had here for today. Oh, we did talk really quick. Caffeine. Why don't you drink caffeine?
So I have fought a diagnosis for a really long time of anxiety, and I got diagnosed with postpartum anxiety. And you are like 40% more likely with PCOS to struggle with depression or anxiety. And it's multifaceted. Some of it has to do with, like, most women with PCOS feel like their body is betraying them. I can't have a baby. I have facial hair I have to shave or whatever. My hair is falling out and balding like a man. And like, my body, I can't lose weight no matter how hard I try. It's like my body has betrayed me. So there's like depression, socio impacts of just the physical manifestations of a condition like PCOS. But you're also just at baseline because of some of the hormonal pieces at higher risk. And I started treating my anxiety in a postpartum scenario, and it changed my life. And then first, I have always been my first guinea pig. Like, I'd try it on myself first. And so I've always been really in tune with, like, this impacts my body this way. This impacts my body this way. I grew up in Seattle, and one of my first jobs was a barista. It's like a lot of coffee culture, and I just love coffee. I love coffee. But I found caffeine was really impacting me. It would impact my ability to sleep. Even though I drink it in the morning, I still would have a harder time falling asleep at night with any caffeine exposure. So I just found that my body doesn't agree with it. And I find a lot of patients of mine, once we switch them to decaf, it's really beneficial. I'm also not on birth control and in my fertile years still. If I were to get pregnant, my risk of my child having leukemia, like, there's high levels of caffeine consumption increase risk and can increase the amount of time to ovulation. I have a whole episode on caffeine intake on the Food Freedom Fertility podcast. So if you've had recurrent miscarriage or you're struggling to get pregnant, caffeine is a low-hanging fruit typically to at the very least decrease. And the common recommendations from ACOG, the American Academy of Gynecology and Obstetrics, I'm saying that backwards, obstetrics and gynecology. Anyway, they recommend 200 milligrams or less of caffeine per day. And if you go dig into all the research, there's no good reason for that specific amount. And so for me, I just say the less is better, because I'm lowering risks and it not messing with my anxiety, and just kind of better all around.
Interesting. Did not know any of that about caffeine. So, cool. Well, to wrap this up, where can people find you, Caitlin?
Yeah, I'm at PCOS Fertility Nutrition on Instagram. That's kind of the main platform I hang on. We have a app called the PCOS app. If you go look for it in the Google Play Store or the Apple App Store, it's like a pretty little purple flower, bluish purple flower. We release recipes that I've written and photographed. We release a weekly podcast that's exclusive for that. That's different than my fertility podcast I do with another integrative dietitian. It's called PCOS Answers. And we, instead of doing like a 90-minute episode, we talk about one thing with really direct application. So like why you would want to eat a savory breakfast over a sweet one, and practical examples on how to really implement that. I have really high ticket courses I used to sell, and now they're all within the app for $10 a month instead of paying me $700. So really trying to increase accessibility to the type of information that's going to change your health. So there's a lot there in the PCOS app. There's a free version where you get, a good amount of stuff, but not all of it, if you just want to dabble with it. And then in the supplement world, if you go to PCOSformularies.com, we have supplements that help PCOS infertility. We have supplements that help PCOS, insulin resistance, and weight loss. And they're uniquely formulated to have kind of clinically based dosages of particular herbs or compounds, like N-acetylcysteine, for instance. It's not an herb. It's a precursor for a really powerful antioxidant in the body. So we have stuff like that has been designed specifically for PCOS to help with weight loss, insulin resistance improvement, symptom management, and specifically fertility. So that's a great source too. There's so much free information online in my Instagram community and in that PCOS app that there should be no reason to walk into a doctor's office not feeling confident in what you want to ask for and how they can kind of work alongside you. If I could leave people with a message at all about PCOS, it's that it's very treatable. You can live a really beautiful, very healthy life, even with this condition. You can get pregnant, even with this condition. I've helped thousands of people get pregnant. I have a wall of babies that I look at every day, and there's a lot of hope. So even though it's hard and we're talking about insulin resistance and behavior change and all these things, you are stronger than you think you are. And actually, I know that for a fact. If you have PCOS, because you have more testosterone in your body, you're much stronger than you think you are. And we can use that to our advantage.
Well, thank you so much. This was very informative. We went a lot longer than I thought we would. And we went down some good rabbit holes there. So thank you for coming on.
Yeah, you're so welcome.
I definitely think there's more questions I have now, leaving with things we could talk about in the future potentially.
Yeah.
So. All right.
Send me another scheduling link. We'll be back.
All right. Well, thank you very much, Caitlin.
You're welcome.
84% of you that listen to this podcast frequently do not hit the follow button. If you've enjoyed any of these episodes, could you do us a favor and hit the follow button, leave a rating, and maybe leave us a review? It helps this channel more than you know, and the bigger the channel gets, the bigger the guests get. If you'd like to know more about training in person or online with Brett's Gym, Architect Fitness, please follow us on social at ARKITECT Fitness on Instagram or visit ARKITECTFitness.com. Or if you want to rehab with barbell therapy online or in person, check out @barbell.therapy or visit barbelltherapyandperformance.com. Thank you for taking the time to listen.